and welcome to the afternoon session. It's my great pleasure to chair the next session, and the latest in the line of very high-profile speakers who we're very pleased to welcome to help us launch Prime Centre Wales today. I'd very much like to welcome to the stage Dr. Ruth Hussey. Ruth, as many of you will know, is Chief Medical Officer for Wales. I'm not going to say any more biography because it's in your handouts, and it's important that we give Ruth time to speak and time for some questions at the end, if that's possible. So, without further ado, I'd like to welcome Ruth to the stage, please.
Wel, prynawn da, diolch yn fawr iawn am y siawns i fod yma heddiw i siarad gyda chi. Good afternoon, and thank you very much indeed for the opportunity to be here today and to talk about some really important issues and things very close to my heart. I'll basically sketch what I think are the issues that we might need to face up to and deal with over the next few years, and I will try and leave some time for comments and question at the end too, recognising you've got a very busy schedule this afternoon. So, the overarching set of issues we face, I suspect I'm going to potentially cover ground that other people have already talked about today, so I'm going to gloss over the issues, not because they're not important, because I think you're well familiar with them. Our challenge is to respond in a way that designs interventions and services that better meet the needs of local communities and produce the best outcomes we can for the population. How many people have heard of the Wellbeing of Future Generations Act? I strongly recommend you have a look at it. There's a short guide to it called The Essentials on the Welsh Government website. It was passed and had royal assent in April this year, and it goes live next April. And what it does is potentially a game-changing requirement of all public bodies and governments to think about the long term, to put prevention in the heart of what we do, to integrate services wherever possible, to collaborate effectively, and to put co-production with the public as part of the essence of how we do business in Wales. And I'm glossing over it, but I strongly recommend you have a look at that, because for me, that really sets the context and the type of response that I think people are looking to us to start to drive hard, to stop being in silos, to push and push for why aren't we doing it across sectors. You know, the housing sector at the moment, passionate about what they can do to change people's lives for the better in partnership with the healthcare system, and in the process reduce need for healthcare. And the great business case, great examples all over the place. Fire service came to see me yesterday, desperately keen, have a resource, we can help. I've had a presentation today from a colleague in the northwest of England who doing amazing things with local governments, major drivers in recognising that health impacts on the economy and therefore the prosperity of a local area. So the Wellbeing of Future Generations Act sets high-level goals, one of which is people will be healthier. So there's an overarching context which I think helps us to understand the imperatives to push and push the boundaries of our expectation. Now, I'm only in slide 2 and I'm mentioning prudent healthcare. How many people have heard of prudent healthcare? Everybody, because the Minister talked about it this morning, I am sure. And I'm sure he said that this is recalibrating, if you like, the relationship with the public, thinking through why we, in some instances, undertreat people and in other places, overtreat, over-medicalise solutions and don't get the best results for the people whom we serve. So I won't dwell on it too long, but just to say, increasingly drawing interest from outside Wales. I was lucky enough to speak at a population health meeting in Australia recently, bowled over by the Future Generations Act and also prudent healthcare. Other countries struggling with the same issues that we're struggling with, so we're not alone. You know, loads of people are facing similar types of how do we respond in a way and change the system we've had since 1948 to better meet the needs of the population and work as true partners. So what are we trying to do in primary care? Well, I'm really pleased that as we developed the prudent healthcare conversation last year, the Minister also said, and that's the year of primary healthcare. and I'm sure he will have said, he's put new investment into primary care, realisation that we really, if we wanted a fundamentally prudent healthcare system, that the place to do that is in primary care. And all the evidence base, which colleagues in the room have worked on to help share with us, is that the models of care, the sustainable healthcare systems build from strong primary level care. But it needs to change and adapt in its style. But the basic tenet of why we need it is strongly evidence-based. The other thing we've been trying to emphasise is this isn't about medical solutions. Increasing interest in where partners can help, where housing, where social care, where leisure services can help, can play a role in offering alternatives to medical treatment, or certainly support the prevention of chronic illness. We know that large proportion of our population living with chronic illness, much of it preventable. We know from the Caerphilly study, major piece of research that tells us if you do all the 5 healthy living things compared to doing none of them, you can reduce diabetes and dementia by between 50 and 60%. Preventable illnesses, and we really need to work on the whole package of healthy lifestyle, not just one of them, but actually how we bring all of that together and create conditions in communities where people can actually enjoy good health. Even if they have developed illnesses, how we can help people have healthy life expectancy is the big challenge for us. So what we're trying to do? Well, through the primary care plan, pushing integration, encouraging cross-thinking about how we organise our services, reducing handoffs, reducing overlap, making it simple. There's a nice example on the Prudent Healthcare website from Llanelli, where the whole team got together across agencies and realised that they could streamline their patient-facing service, client service, and were able to reduce the waiting times and get better results, better meet the needs of patients with the same resources by prioritising and working better as a team. Team-based care is very evidence-based. We had the NUCA model presented to us, colleagues in Alaska last year, and when they look at all their measures of quality and outcome, the big message that came across was team-based care gives us the best results. And we've seen that so many times in other settings too. So really trying to emphasise that how we break the boundaries between each of us and our professions. Making sure that we've finally done something about the inverse care law. We sort of say with pride that Julian Tudor Harting described it first in Wales. Well, I'd like to be the first place to have done something really powerful, to have reversed some of that pattern as well. And I'm pleased that we've got projects underway at the moment, really trying to push that inequity that we have around primary care. And all that needs strong leadership. And as you know, we've appointed a national clinical director for primary care to really bring I think that the visibility and the professional leadership role into the foreground. What about emergency care then? What are we trying to do in emergency care, and how does it link across with primary care? Well, you know all of this. Getting the right treatments to the right people at the right time. We've launched the emergency medical retrieval service. There's lots of examples where we're trying to make sure we're matching what's happening in communities, both in terms of rural and urban, different models needed in different places, really trying to tweak the system so we best meet those needs in a timely way. Really trying to drive prevention. Even in emergency care, there are preventive things that we can do that we should be picking up. And trying to get a better understanding of public choices. We create a system and people use it. So if we don't like the pattern of use, we've created that system, and that's what you get when you create a system that does it like that. So are we in tune with what people need in their lives? I remember changing a service many, many years ago when we asked them, why do you go to this A&E department? There's a great GP service down the road. And they said, well, if I go to the GP, they might say to me to go to the A&E, and I've only got one taxi fare. And secondly, I don't have to negotiate. I can just go in and I know I will be seen, and I'm prepared to wait, but I know I'll be seen. Now, that's going back years. But is that still relevant today? Are we really in tune with choices that people make in their lives? I won't go through all this, but patient experience drives the way we use our systems. And we need a strong workforce. We need to design jobs that people enjoy doing as well. So real challenges for us to match all of those things together. There's a lot on this slide, but just to emphasise, I guess, when we talk about emergency care and scheduled care, we really need to go right back to that first point of contact and think through, have we designed everything that we should be offering in that first point of contact? Or do we only have a menu which says either GP out of hours or hospital? Have we got a broader based menu of choices that we can offer people? You'll be aware that we're working on the 111 model of care. Now that's one level you can say, what's a phone number? I wish they'd stop saying it's a 111 model, because what it really means is 24/7 care in the community. The mission is to create services, a choice of services in the community that better meet people's needs. And I won't go through the list, but obviously, at each stage, have we thought through, have we chunked up our thinking in a way that gives real alternatives all the time, better quickly intervening before things escalate further. So an agenda there, which you could, I think, from a research perspective, is ripe for a partnership with academia to test out different models and different ways of working. So how can research help? Well, first of all, you've got evidence that we need to know about, but putting it in a digestible format, summaries, reviews, the fact I mentioned that primary care is evidence-based in terms of a prudent healthcare system, that came from colleagues doing the literature review across Europe and beyond. So we need your help to inform policy. You've got research there now, I would predict, that we could draw upon that would help us understand what we need to do. There are new areas emerging, such as social prescribing. One of my colleagues who's training in public health, really keen to think about how do you systematise social prescribing so it becomes one of the choices, an easy choice. But there's a whole research agenda there to work out how to do it cost effectively and appropriately. Help us identify the priorities. If, from the research you have in the global literature, are there areas that really would be ripe for urgent intervention, if you like, or quick development? And increasingly, how do we develop the right outcomes? We all talk about moving towards an outcome-based approach, but can we measure the outcomes? We're very good at measuring what we do to people. But when I say, well, I was with an optician this morning, I said, so how do you know how many people have benefited from your treatments? And it's quite tricky, isn't it? And yet we've got amazing resources here in Wales, the SAIL database, linked data records. We've got opportunities to think through, did we make a difference in the end? Can we tell people what difference we made, rather than, well, we saw people and we had appointments and we had time, we count the time, but we don't count the clinical experience, outcome, nor patient experience. So patient outcome measures, patient experience measures, critically important. So what are our main challenges then? Well, for me, the 21st century is running away from me. Every month that goes by, I think we urgently need to change and redevelop our services, our whole way we organise care. I was listening to 3 patients last week, all 3 of them with visual impairment now, and they described how when they got to the clinical episode, generally, it was quite good care. There were 1 or 2 things could have been better. But they said the way we organised it made it really difficult to get to the right place. I've heard something similar this morning as well. So the pace and change of improvement is it's not enough to know what the science says about the clinical bit. It's how do we organise it in such a way, end to end, that it's the most efficient and most effective way of doing this and meets people's needs. Tackling inequalities across the life course. And I want to emphasise across the life course. This, the evidence that the first 2 years of life, in fact, the first 1,000 days, so pregnancy and the first 2 years, critically important. It changes children's life chances forever. So where's the research in primary care? The only universal service at that age group is the NHS. Can we do better? We're currently trying to revise the Healthy Child programme. What else can we do to absolutely make sure children get the best start in life? We know that will break the intergenerational transmission of disadvantage. Critically important part for us. I could go through the life course. Same with the working age population. Being in a job is crucial to good health, a good job. How much is health stopping people getting into work, and can we do more, particularly around mental health? And then thirdly, ageing well. You know, keeping people independent for as long as possible is a critical mission for us. Where's the research that will help us be prudent across that life course? That's, you know, my agenda in terms of what we need to do. So what do we need to understand? Well, one of the prudent principles is about co-production. And a lot of people say to me, oh yeah, I do that. I work in partnership. When you actually talk about it, it's, well, you know, do we really trust the patient? Same conversation I had with a clinician this morning. Yeah, well, we need to follow them up to check up that they've, you know, it's okay. Well, a co-produced relationship with chronic health problems is actually the patient takes responsibility too. It is a partnership, and we've got to rethink a little bit about how we deal with that relationship. And I know there's great work in Cardiff and beyond in Wales looking at shared decision making. So have we systematised it in a way where patients say, yeah, I'm a real partner in this, I take my share of that decision making. I've mentioned 24/7 care in the community. We urgently need to rethink the options. You know, most of our healthcare system is caring for frail older people. You'll know that the average age of a patient in the unscheduled pathway in hospital is about 80, 85 now. I also know, and I think we need a level of honesty about this, the decision to admit a frail older person carries immense risk. And I think we need an honest conversation about when does that balance tip? And do we just admit because there's nowhere else? And I suspect we need to get to a point pretty quickly where we say, actually, the level of harm of taking somebody out of their secure environment to get some clinical treatment is going to be counterbalanced by the discontinuity, the confusion, the unfamiliar surroundings, and the physiological stress of not knowing where you are, etc., etc. There's a real fine balance now. I've witnessed it. I talked to my colleagues, many older, their relatives. Minute they get into hospital, catheterised, put in a bed, and you know they're going to be in hospital for weeks trying to get back from that position. So really need to challenge, have we got the alternatives in place in the community? If we're truly serious about a primary level care service, we need to push that boundary further. Digital technology, I was really struck by the clinicians in Bangor who said to me, we realised we were offering low value 10-minute outpatient appointments and bringing people 2 hours each way for the privilege of that 10-minute consultation. So telehealth being tested and developed in North West Wales. But how much more could we do? You know, we're digitized in everything else in our lives now. And I know not everybody's in the digital revolution, but it's astonishing the pace at which the whole population is taking on the digital world. So have we really tested the boundaries of that? I'm getting the wave to say to shut up. Waste, thank you. Waste and over-treatment. Examples over and over again. One of my team, one of my staff, she said, I've got a bin bag full of tablets at home. Just repeat prescriptions. We told them we don't want them. And she said, what do I do with them? They're waste. You can't reuse them. So, you know, we've got to do something about this sort of system that drives a pattern of response. So, things that we should think about then, and perhaps principles of how you might be able to help us. Matching priorities to the needs of the population. Really trying to develop new research methods. The other dilemma we've got, the pace at which we need to reshape what we do, means we haven't got 5 years to do a randomised control study on everything. We've really got to rethink quick research, different models, patient engagement in that research process. And, you know, really helping the population be our partners in research. We're consulting at the moment on a green paper on quality and governance in the NHS. There's a question in there about people's rights to be involved in research. we've started this programme called Healthwise Wales. Many of you will be familiar with it. Now, on the surface of it, it's a cohort study to recruit hundreds of people from the population to be partners in research. My ambition is that we use that to say everybody has a right to be involved in research. It comes from that sense of, actually, it's my knowledge as a patient. I can help somebody else because I know what it was like to do use this service. How do we systematically get people's voices and listen to them carefully? So I have huge ambition for Healthwise Wales as a means of really bringing people power into our way we think about research, who owns the research and who does something about it. I think it's a real opportunity to change the relationship. And what about these 64 primary care clusters? How do we get patient voice strongly driving what needs to change? What are the questions that trouble people? The holistic questions that we can answer. So I need to wind up here. I hope I've given you a few suggestions, ideas of what's on my mind, at least, in terms of the importance we attach to primary and unscheduled care and the opportunities to really challenge the current thinking about how we respond to people's needs. I also hope you realise there's an awful lot to do, and there's plenty of material and work for all of us to crack on with over the next few years. So thank you very much. I'm happy to answer a few questions.